I'm Rob.
And I'm Mike.
And welcome to another edition of Let's Get Ethical.
Oh, I like that.
Oh, that's sweet, man. That new fancy, shiny intro.
I like that. You guys have no idea how many videos I've been sending Rob. I'm a mess.
I'm inundated.
Yeah. I'm like, how about this one? How about this one? How about this one?
Awesome.
And I finally got Rob to say, I like that. So here we are. Yeah. I'm like, So welcome back, everybody.
Yeah. Welcome back, everybody. Thank you for joining us. Mike, before we begin today,
yes,
we have a special birthday to celebrate.
Let's celebrate it.
Want to give a shout out to my fellow veterans and all the men and women of the United States Navy Hospital Corps. 128 years in the making, the only enlisted corps in the entire military branch. So thank you to all my fellow docs. I appreciate you, and keep on going out there and doing a good job. Thank you very much.
Thank you for your service, and happy birthday. That's awesome. We need to add some music or something to that.
We should have. We should add like
absolutely need to add some music there. Yeah. So just really quick, the ARC updated on June 10th. We're a couple weeks out from that now, but on June 10th, and maybe by now they've updated again. They updated they got an update from Mayo. They have a response. But you know what's interesting to me, Rob, is I noticed just in doing more research, because I'm like kind of scope locked on this for some reason. I'm a little one-sided about it, obviously, but I've noticed that they have the reasons that they give. None of them include cost savings, and that's a problem with me. Because their goal is, and they're focused on improving quality of care. And I'm not sure how to do that with removing somebody from the night shift. And I know we'll get to that. We'll get to that in a little bit. We're not getting that just yet, but it seems to me that all the conversations that we've had have been between, you and me, RT Sidebar. None of us work at a critical access hospital, right?
No, I've never worked at a critical access hospital. Have you?
Neither have I. No, I haven't either. So it makes sense that we should be having this conversation with somebody who does, or someone who has, and someone who's got that experience, right?
I agree. And, I think today's conversation is it's a compelling question. Yeah. And I really, to your point, I really want to draw on the real world series, right? So we want stories from the bedside, the ethical, clinical. What are the community implications if we remove respiratory therapists from overnight staffing coverage in critical access hospital? And I think to our point is let's move beyond the productivity and the budgets and the staffing numbers. And I think I want to help our listeners to really understand what is potentially lost when RTs are no longer physically present in our rural critical access hospitals.
Right. What's at stake?
What's at stake?
Absolutely.
Exactly. So what I'd love to do today is we have a fan of Let's Get Ethical.
We got one.
We have one. We have one solid fan, and we love that. So I would love to bring in Jill Wolber. So Jill, come on in. Let's enter the stage of Let's Get Ethical. Jill, welcome to the podcast.
Hello. Hi.
Welcome, Jill.
Welcome.
Woo. I am a fan.
Thank you. We love that. We are very excited to have you today. Hey, listen, all it takes is one.
That's and we'll take it.
And we'll take it. Absolutely. So, Jill, a little bit about you before we really get into what Mike, I love to call going down Alice's rabbit hole, because that's what Mike and I are very good at, because everything with ethics can be a rabbit hole.
100%.
You've been an RT for nearly 30 years. Is that correct?
Yes.
And you're a critical care therapist. You've done neo and peds and adult. You've even worked in tele ICU. Right?
Correct.
Nice.
Correct.
Okay. Wow. And Jill has her respiratory care degree from Reading Area Community College. I'd like to point out she has a Bachelor of Science in Healthcare Administration from Immaculate University. And she is currently seeking to complete her graduate degree in healthcare compliance and ethics and is attending the Drexel University Thomas R. Klein School of Law.
Wow.
Now
you have that down.
Awesome. Yes.
Right?
So many roles. And Jill, in your own words, and I'm just going to say this because this is exactly what you said to us the other day, that you have basically a deep passion for evidence-based respiratory care. You have a strong commitment to ethics and education, and you want to improve our patient outcomes. And we're really, really excited to have you with us today.
Yeah.
And if I remember correctly in our conversation, you most recently, you worked at a critical access hospital as the night RT, right?
Yes, for the last 1 year and 1 day, to be exact.
As the night RT.
As the night RT, yes.
Oh, wait,
the night,
really quick.
Yes, go ahead, Mike.
We have critical access, we have night RT, and somebody who's worked in telehealth.
Correct. I also taught respiratory for 8 years.
But why
Yes.
someone like you would be prime for this conversation that's been happening regarding Mayo?
Correct.
I'm so happy you're here. We can finally have a conversation where we're not just necessarily speculating anymore.
Right.
We can actually get some facts about what's going on. That's awesome. I'm excited.
Yes. I'm excited to talk to you about it.
I think what is so cool about having you on, and what I'd really love you to kind of tell us and our audience is give us the story, Jill. Tell us why it is so important that we have respiratory therapy present in these critical access hospitals, in the trenches on the front lines. Tell us that story.
Yep.
Okay. For one, we are the only critical care trained people in the entire hospital besides the ER doctors.
Wow.
That's one. And the ER doctors will tell you they don't consider themselves critical care trained. They consider themselves emergency room trained. So there's that. There are no anesthesia in house at night. They will get called in for labor and delivery, but they will not come in and do anything else. So where I was, it was a 18 bed med surge, 4 bed labor and delivery, and a 21 bed ER. But at any point, that ER could have standing room only. It's a touristy area. So in this season, you could have numerous amounts of things. Respiratory was in charge of conscious sedations. We were in charge of all labor and deliveries that would go awry, which we could have preterm babies. We could have bad C-sections. We were supposed to have 2 RTs on at night, but Saturdays and Sundays, we only had 1 on from 10 p.m. to 7 a.m. So I could be in the emergency room in a code or a ventilator situation and be getting called to a delivery on one person. And let me tell you, this happened numerous, or I'd be called to a conscious sedation. So this would happen on numerous occasions. There was many times where the med surg nurses would call me for simple things like oxygen. They don't even have ACLS. They don't have PALS. They don't have any of that stuff. So, I mean, literally, I'm running around all night doing things that in the larger hospitals that I came from, I never would have been called to do. It is imperative to have an RT in-house at a critical access hospital because near sentinel events were happening all the time. To be honest, I felt like my license was on the line.
So when you hear, and this might cross into, Rob, just so you know, this might cross into a not so good area for us, but I'm gonna do it anyway because that's what we do.
That's what we do.
We toe the line and we cross the line a little bit. When you hear that Mayo is stating that their decision was not based on, and I'm going to bring up cost again, not because I want to talk about cost, but their decision isn't based on a cost savings or from a cost savings vantage point, but that it's based on improving quality of care by removing the overnight therapist and replacing that with telehealth. What is your initial thought with that statement? And in terms, and be however honest or open you want to be or don't want to be is up to you. And I totally understand no matter what.
Right.
How do you feel about the truthfulness of that statement? This is where, Rob, I crossed into a bad area. How do you feel about the truthfulness of that?
That statement ripped me to my core. As someone who did telehealth, I did telehealth, but there was also bedside RTs. The telehealth portion was a backup safety mode for the bedside RTs. We were not in place of the bedside RTs. We were in addition to the bedside RTs. So if a bedside RT would text me and say, hey, I can't get to room such and such, could you do a vent check for me? Yes, I can do a vent check for you, but I can't place hands on that patient. I can't listen to breath sounds for that patient. I can't do a plateau pressure on that patient. So you are going to need to get to that patient at least once that night. But I can do one of the checks. So we are in addition to.
Right. So now when, and I know there's somebody out there going, but wait, especially Mayo, it's been very clear. They already have implemented this at another facility and it seems to be working fine.
How long has it been implemented? Do you know? Because I don't.
Rob, do you remember? I know I'd have to go back to
I think it's been a year. I want to say it's been a year.
Okay, let's call it a year. It's been enough time that they have decided that in the rural I can't say the word rural community. Yeah, thanks. Yeah. In a rural community, there I did it. They find it as an improvement in quality and safe to do. Now, I don't live in a rural community. I'm in Southern California. Rural to me is, I don't know. I don't have it. It doesn't exist. It's, I live more than 10 minutes from the mall.
You have no rural where you live.
I don't know what rural is. I have lived in rural communities and I moved away from them because, wow, I'm a city boy though. I'm grown in the city. So whatever. So I don't know much about a rural community. You guys would probably know more than I, especially having worked at a critical access hospital. Is it different? How different? Where do the differences lie? For those of us who don't know, and this is a question for you as well, Rob. For those of us who don't know, what does that mean? It comes across to me as though there's a difference in need, and I can't imagine that. People get sick, people need, and they need the same stuff they need at Loma Linda. This
is my first experience living in a rural. I've always worked in level 1 trauma centers, 600 bed hospitals, 800 bed large hospitals. So this is my first experience. When I started here over a year ago, and I would say things like, oh, we can have high flow. And they're like, we can't have high flow in the med-surg floor. I'm like, why? It's a heated, humidified nasal cannula. Oh no, that's like a BiPAP. Like, it's nothing like a BiPAP. Their idea of what we do is completely different of what a non-rural place is. So even a heated high flow nasal cannula has to get sent out to a level of higher care, which blows my mind. So they keep nothing. Anything over 4-liter nasal cannula, sent out. Anything over a heart rate of 120, sent out. These are the things that I was like, what do you mean? Like, you can't keep a heart rate over 120? Like, these are the things that I'm like, so that's the difference between a critical access hospital and rural and so you're talking, it's almost like it's an urgent care.
Mm-hmm.
So
that's the difference. And that's kind of the mentality. There's no pulmonary, there's no nephrology, there's no cardiothoracic, there's no, so all the things that I'm used to, there's no IR. They don't do ERCPs. They don't do half the things that I'm used to doing. So when somebody would come in and I'd be like, all they need is to have their lung tap for a little, oh, we don't do that. So we're sending them out for a 5-minute procedure. So that's the kind of stuff that it's to wrap your head around and thinking that, you're either costing someone this huge ambulance ride or, for God's sake, a helicopter ride for a 5-minute procedure.
But you still get, you're still an ER. So you still get anything that comes into an ER, and you still need,
yes,
you still need critical thinking, critical care. You still need that ability on site, right?
But you don't always have that, because you have, like, they'll hire new grads in the ER. So you don't always have that. And then there's a lot of locums that come in to work as doctors because they can't always get people, depending on where this critical access hospital is. Like, it's very interesting. It completely changed my mind. But what Mayo is doing is, I'm not in agreement with it. You need critical care trained people in the hospital 24/7. And if that's your RT, that's your RT.
So along those lines, sorry, Rob, I've usurped the interview again, as I do. I apologize.
No, that's okay.
I love the word usurped anyway. Sorry. Along that same line, without a therapist there overnight, which patients become most susceptible to, I'll use the word damage, as a result?
Your med surge and your labor and delivery patients, the ones who are not in the ER.
Oh, wow. Okay.
Yeah, because they're the ones who, so labor and delivery, for example, when the moms are having, decelerations when they're in labor. I know for a couple of times I'd walk over and I'm like, hey, is anything going on? They're like, no, we just have a mom who's, she's having some decels, but it's okay. I'm like, I'm sorry, what? I've worked in NICUs, level 3Bs and level 4s. And immediately my little horns come out. I'm like, okay, can I put her on non-breather? No, mom's SATs are fine. No, it's not for the mom, it's for the baby.
Right.
And they're like, no, we don't do that here. I'm like, nope, we should do that here. So I finally got them used to doing that. And then the OB would be like, oh, the decel stopped. Isn't that amazing?
Yeah. No asphyxia. You're right. Yeah.
But that's my whole thing. If an RT's not there, they had no clue about that.
Huh.
And they did have a lot of issues. I mean, it's almost like a unsaid thing here that, some of my neighbors are like, yeah, we won't go there to have our babies. But but if you are driving in labor and this is the only place to go within an hour,
right,
and you can't make it somewhere else, you're going to go there.
Right.
So these are the kind of things I'm talking about. Critical care trained people need to be in-house 24/7.
In the emergency department, it's really, it's an extension of the intensive care unit, whether you want to agree with that or not, right? We provide critical care services. We intubate patients. We put them on mechanical ventilators. We do non-invasive ventilation. We give medications. We do conscious sedation. We start drips. It's an extension of the intensive care unit. And to your point, Jill, is who's the critically trained person that's there, and what happens to the potential risk to the patient when that critically trained person is on the other end of a video screen.
That's my point. So when I worked in telehealth, I could explain things till the cows came home, which I always laugh because when I lived in Pennsylvania, they said, oh, the cows come home at 5 a.m. I'm like, I work night shift. That doesn't make me feel any better. But, so if I'm working at 1 a.m., they're not going to come home. But anyway, you can explain things till you're, blue in the face. I can tell them, push that button, push that button, push that button. That's delay of care. It's delay of care when I could be there doing it. And you guys know, as RTs, troubleshooting is half of what we do.
Right.
Turning buttons is the least of what we do. The troubleshooting is all about, and, everybody's not on a PEEP of 5. Everybody's not on a FiO2 of 50. They're not on a tidal volume of 500. Everybody is different. Everybody's unique. I don't believe that you can just put someone in a box and call it a day.
Well, and I also think that, if I'm telehealth, I'm relying on your subjective perception of the breath sounds that you heard.
Yes.
I don't know how good you are.
Beat me to it.
Yeah, I don't know how good you are. Your perception, I can't necessarily see the color unless you put the camera on the patient. I don't necessarily see so I'm relying on this person's perception, this person's subjective take. I personally, I rely most on my own subjectivity.
Yes.
And so that worries me,
Yes.
especially based off what you just said, where if we're the critically trained person on that floor, on that med surg floor, we're relying on somebody who's not critically trained to give us information about some critical information so that we can then, I'm saying critically a lot, critically think, and relay the information. Never mind the delay. And the delay, you're right, that's significant.
Correct.
We have to ask, they have to do, they have to relay, we have to give an answer, they have to act.
And
it's no longer decide.
Time is brain. Time is brain.
It's no longer evaluate, decide, and act anymore. Yeah.
Yeah. And if somebody needs an endotracheal tube and you're delaying all that care and they're not getting oxygen to where they need it, we all know about, anoxia and all that stuff. So that's just a whole nother road to go down.
Right.
But the thing that really bothers me is, how many times have we as RTs been called for a PRN breathing treatment for wheezing, and you get there and it's not wheezing, it's crackles. I mean, honestly,
more times that I can count.
Correct. Because notoriously, I love my nurses, but they will call crackles wheezes. Completely different beast. So, there's that too. So breath sounds are, I'll say it, respiratory is the best at breath sounds.
100%. That's one.
That's our bread and butter. It's our bread and butter. Yes.
Of the many things that we learn in respiratory school, that is one of the top things, right? That we're the experts, right?
Yes.
They're calling us because you're concerned about your patient's breath sounds and you want our assessment skills and you're asking us to participate. You're asking us for, hey, what can we do to help this patient out?
Absolutely.
As I listen more, for example, again, I'm hearing, the Instagram and the TikToks, a lot of mid-level providers come out and saying, hey, I'm the only NP on at night in this intensive care unit. I need my RTs. I rely on my RTs. They already know what they're doing. They got the vent settings. They're getting the blood gas. They're assessing the patient. They know what changes to make. Mm-hmm. I don't know all that stuff. That's why I have an RT here. You raise a good point, right? When you are the subject matter expert in that critical access hospital, you are making the difference. You're not fiddling around trying to figure out how to set up a patient on BiPAP. You are talking to the patient, you're applying the mask, you're applying the therapy to try to prevent the patient from being intubated.
Correct.
When the patient's intubated, you're going to work to think, okay, how do I reduce the mortality of this patient who now is going to get transported, whether by ambulance or by helicopter, and ended up in an intensive care unit? It's true, and I've said this to many, I worked on a transport team for years, that many of the RTs that I ran into in critical access hospitals, I would say the decisions that you make here in real time in the trenches can have a difference in the outcome of the patient.
Absolutely.
Right. So it's vital. And, Mike, you and I, we went through, we looked at the 3 hospitals. We know that one of them is, I think we said it was psychiatric.
Right.
One of them was like a chronic.
That one might make a difference.
Yeah, we don't argue that, right? And I think one of them was a chronic ventilator facility. Mm-hmm. But I want to say the other one was like 150 bed community hospital.
Oh, wow.
No, the other one, it wasn't. No,
maybe I'm wrong.
The other one, oh gosh, I can't remember. And that's on me, Rob, because I told you that I got bad information. There are 2 hospitals within 20 minutes of each other, and I was combining the 2. One's like a 50 bed, one's like an 80 bed or something like that. Okay. But they're under 100, but that other hospital is like somewhere between 50 and 80. I can't remember off the top of my head.
That's still bigger than the one I was at.
Right.
I mean,
and here you are as an RT. That 21 bed ER, that's a big ER. That's a good size emergency department. That's not a small little ER. Yeah. And so when you're talking, go ahead, Mike. Sorry.
I was just going to say really quick before we get back to that. I'm sorry, Rob. For everybody that we've angered at this point, let's draw them into the conversation in a positive way. Because Rob, you and I, and Jill, people who believe in telehealth. Mm-hmm. And we know people that are like, no, it's a good thing. And I would not argue with that. I don't think you guys would argue with that.
No, not at all.
There's a place for telehealth. Jill, really quick, so that all those people that are angry, all those people that work in telehealth that are like, oh, we hate you now, can hate us a little less. There's a place for it. Jill, can you speak to that?
Absolutely.
There's a place for telehealth. Yeah. What model would, having worked in both, do you find would be the best, or that you've experienced would be the best?
So part of my job in telehealth, I had two jobs. One was monitoring all of the ICUs for this large, you don't want me to say the name of it, right? Of the large organization I worked for. And then the other part was I actually manipulated the ventilators for the organ donation.
Wow.
Okay.
Wow.
So that was very rewarding, because once we took over the ventilator management of the organ donation, our lung donations went up by 40%.
Right. Wow. Because your oxygenation of the tissues was improved, I'll bet.
Yeah.
Plus everything else went up. The hearts, everything else went up too. But we took that away from the organ procurement coordinators, because they were just going by their old algorithms, which were like 30 years old.
Right.
So once the RTs took it, so that was fascinating. Telehealth definitely had played a role in that, because manipulating the vents, I think we were 6 miles away from the building. So the bedside RTs would have to actually come and get the patients and take them to CAT scan and take them to the OR, and that, because obviously I couldn't do that through the computer. Right. But they didn't have to come over and like change the vents every time we thought that the vent needed to be changed, which was wonderful.
So you're advancing.
The nurses could draw the blood, the blood gases off the lines and all that stuff. So the nurses were one-on-one with the donor patients. There's 8 donor patients max in the unit. And the nurses were one-on-one, but we decided if they were going to be prone, we decided if they were going to be bronched, we decided if they were, the vent changes, we did all the vent changes and everything else. So telehealth was wonderful for that. And it freed up the bedside RTs that they didn't have to do that. So they loved that idea. So telehealth, and actually there was a paper written on it.
So a great example of where, when we talk about growth of the profession, and I see it all the time, is respiratory.
And I love doing that. And I told her if she'd let me do it from home, I'd still be working for her.
You make a good point, right? We're saying that, look at how diverse, right, we can be as respiratory therapists.
Absolutely.
I can be 6 miles away, monitoring the patient. I can make changes in real time. I can see what's going on with the patient, but I'm still using my skill set, right? My skill set's not diminishing. I'm still using and drawing upon everything that I know about mechanical ventilation, and mechanically ventilating a patient that you're trying to get lungs on. It's very
plus I'm
different.
doing optimal PEEP, and I'm doing plateau. I'm doing maneuvers, and it was so cool. I love them. Plus it was very rewarding.
Yes. So, here's what the point I want to highlight is that as a profession, we're continuing to grow and we're continuing to advance. Yeah. We definitely pointed out today, the importance of why respiratory therapists should remain in critical access hospitals. And Jill, you did a really nice job of highlighting for us.
Thank you.
You're the only critical care person. You're in the ER taking care of somebody with COPD, and next thing you know, you're going to meconium delivery.
Yes.
Right. Or a 9-year-old asthma kid rolls through the door, and you've got to shift those gears so quickly, because every one of those patients is different.
Correct.
Right? And the respiratory therapist is the person in the hospital, in the ER, that has that skill set and brings it to the table.
Right.
So, Mike, I think this is a great place to close out for today. I have absolutely loved this talk.
Jill, thank you so much.
Yes.
Oh, thank you guys. This was fun.
You gave us a lot of good knowledge that personally, I'll speak for myself, or you can speak for yourself, Rob, I didn't have. So you brought a perspective that I think is necessary in this conversation. So thank you so much for that.
Oh, you're welcome. 100%. I mean, I lived it, so.
And that's important. I mean, that's huge. Yeah.
Right. All right. Well, thank you, Jill. Thank you very much. And thank you, everybody. And join us next time on Let's Get Ethical.